Dear friends, in this lecture, we are going to talk about the role of nutritional stewardship in critically ill patients in the ICU. As we all know, like any form of stewardship, be it antimicrobial stewardship, be it steroid stewardship, be it oxygen stewardship, they have a very big role to play in the care of the patients. And nutritional stewardship is also very important for the simple reason that excess of nutrition is as likely to cause harm as its deficiency. Therefore, maintaining a balance is very important when the patient is in ICU in terms of meeting the nutritional needs. It is often asked that how much are we convinced that nutritional stewardship actually influences the outcome in the ICU? And although no definite answer exists to this question, but there is no denying fact that the patients who recover nicely in the ICU and come out of the ICU hale and hearty are the ones in whom the nutritional stewardship is practiced. Therefore, nutritional stewardship is critical to a large extent among many other factors on successful recovery of the patients. Then what is this nutritional stewardship? Although various different amalgamation of scientific concepts have been put together to define nutritional stewardship, the one which has been most widely accepted is the one which has been given by the American Society of Parenteral and Enteral Nutrition, and which states that it is nothing but the ongoing effort by a healthcare institution to optimize artificial nutrition use in order to improve patient outcomes, ensure cost-effective therapy, and reduce adverse sequelae. So when we know that excess of something is going to cause harm, we have to also be ensure that our nutritional deliveries meet the optimal requirements so that there is no deficiency which can cause harm. And the main goal of this entire stewardship program is to attenuate the development of malnutrition, because this can hamper or hinder the course of recovery. Let us start with a case of a 50-year-old male admitted with pain abdomen, fever spikes, and vomiting for 2 days, who has history of gallbladder disease since 2 years, is being treated conservatively. And on examination, the patient is having tachycardia. The blood pressure seems to be on the lower limit of normal. Tachypnea, saturation on room air is also on the borderline. Patient is febrile. The ultrasound shows CBD calculus ascites and a collapsed inferior vena cava. And the investigation reveals a high TLC count, predominantly neutrophils, with altered liver enzymes. So following fluid resuscitation, empiric antibiotics, oxygen therapy, measures to control the temperature and pain and vomiting, and planned ERCP reveals cholangitis, for which a stent is placed. And upon shifting, the patient is gradually stabilized in the ICU for over 48 hours. Now, the question is, in such cases, when and how to start the nutritional support? Now, you have to understand that the nutritional phases in acute illness conforms to 3 distinct phases. The first phase is the early period of acute phase, which is immediately following the injury or insult when there is a primarily catabolic state. So this catabolism continues whether or not exogenous nutrition is provided. And if full nutritional support is provided during this phase, then this combination of exogenous nutrition plus the energy generated from catabolism will cause overfeeding, because it will exceed the energy requirements. Therefore, whenever possible in such patients in the early phase, it is good to start enteral nutrition if possible and provide only up to 50% of the patient's estimated caloric utilization, because excessive provision of nutrition is detrimental because of the suppression of autophagy. We know that by suppression of autophagy, the healing process or the body's own mechanism to repair its damaged tissue is hampered. And therefore, such is not a wise step or wise strategy to follow. Therefore, in acute phase, early period, it is necessary to provide only up to 50% of the patient's estimated caloric utilization. The next phase is the late period of acute phase, which is a transitional period where recovery begins, waning of catabolism occurs, and it is in this phase that nutritional administration is ramped up. It is slowly escalated. The third phase is the late phase or the anabolic state with regeneration of lost muscle tissue. And this is the state where full nutritional support as per calculations should be provided. Now, before that, the main important question that can arise is that how can we determine the caloric requirement? The most accurate approach to determine the calorie requirement is through indirect calorimetry, which directly measures both the CO2 generation and the oxygen consumption, and this gives us the respiratory quotient. And this is recommended by many guidelines. However, this is not available so widely, and therefore we have to look for alternate means of caloric measurement. So volumetric capnography is again another technique which is available on many of the newer ventilators. And in this approach, it requires the estimating the respiratory quotient to be about 0.85. And here the daily caloric requirement is estimated as the VCO2 in mils per minute multiplied by 8.2. Although this is a rough estimate, it is not accurate, but still it is believed that this estimate is very near to normal and it doesn't deviate too much. And the third and the important ones are the predictive equations. There are numerous equations available to estimate caloric requirements, and many a times when you open up, you will find those tools freely available on the internet. But the most common approach, however, is to estimate the caloric requirements as 25 to 30 kilocalories per kg per day, commonly as 25 kilocalories per day, but providing extra calories in patients having high fever on ventilator, etc. So this is a rough estimate of the calorie requirement. However, the studies have not confirmed that tailoring this nutritional prescriptions based on individual energy expenditure actually improves ICU outcomes. So we cannot prescribe or we cannot give a guarantee that on calculation of calorie requirements based on any of this. But on the retrospect, if you find out if history of the patients and if you follow the record of the patients who have successfully stayed in the ICU, who have underwent successful recovery after being admitted in the ICU, you will find that most of these patients' needs were met based upon these equations. The question also arises then, how should we assess the nutritional risk? Because there is a proposition that not all patients are of same nutritional risk, and those who are at risk of more risk needs to be aggressively treated, and those who are less at risk may be treated conservatively. However, this is not true. Clinical judgment is required, and the clinical judgment can consider any and all of those factors in varying proportions. One is the adequacy of oral intake. That is, has the patient been on NPO for several days before actually being admitted in the ICU, or had restricted access to food for any reasons? What is the BMI? What is the recent weight loss? Whether there are any physical signs of cachexia like wasting of the muscles, the temporalis muscle or the other thinner muscles and all. So we can also go for laboratory indices, but laboratory indices of nutrition generally fail and are not useful. Although once upon a time they were considered, like albumin and prealbumin. But recently, most of the studies have shown that these indices per se fail to guarantee adequacy of judgment of the risk factors for nutrition when they're needed most. One score has been devised. This is the Nutric score, which was the first nutritional risk assessment tool, which was developed and validated specially for ICU patients. And this included variables like age, HA2, SOFA, number of comorbidities, and days from hospital to ICU admission. The last variable, IL-6, since it is not available widely in all ICUs, so scores were developed both including IL-6 and excluding IL-6. And accordingly, when IL-6 is available, a score of 0 to 5 is computed as patients with low malnutrition risk, and a score of 6 to 10 is computed as patients with worse clinical outcomes, with a greater risk of mortality, ventilation, etc. And these are the patients who are most likely to benefit from aggressive nutritional therapy. Now, this has been reduced by 1 point in centers where IL-6 is not available to make 0 to 4 as low score and 5 to 9 as high score, the other conditions being the same. But the recognition that all ICU patients will respond to the same nutritional interventions, that was the main concept behind the Nutric score, as most other risk scores assessment tools consider critically ill patients to be at high risk score, is something which was considered unique, but later it was not felt the same. So the Nutric score also has its pitfall, and the biggest pitfall is that it fails to differentiate between the effects of an acute disease process, like when there is a shift in the albumin level due to septic shock, where largely leaky capillaries lead to the exudation of fluid from the vascular compartment to the extracellular and extravascular spaces, versus underlying malnutrition, where there is again the same process of similar consequence but different causes. So this is one of the disadvantages of Nutric score, although other scores are there. This score was mostly used because it was validated specifically for ICU patients. However, if we are able to identify the high-risk patients, then the high-risk nutritionally depleted patients should not receive aggressive nutritional support because they also have a greater risk of refeeding syndrome and should receive more conservative support. And some general considerations and nutritional goals apply to these patients when compared to other patients. But it is very important to understand that greater attention should be paid to the initial electrolyte levels, monitoring for the emergence of refeeding syndrome, because whenever a patient has been malnourished for a considerable period, if we suddenly increase the dose of nutrition, this is going to produce a boomerang effect or a rebound effect, giving rise to severe hypophosphatemia, severe hypocalcemia, and ultimately resulting into a cardiac arrest. So we have to identify them by monitoring the electrolytes, and any fall in phosphate level should raise a red flag. And greater attention should be ensured to that these patients reach the nutritional targets in a graded fashion. So most guidelines recommend gradual escalation of calories in the early acute phase, as I told, that is within the day 1 and 2 of ICU. We have to target 25 to 50% of the usual calorie goals, that corresponds to 12.5 kilocalories per kg, followed by 50 to 70% of the estimated energy targets between days 3 to day 7, that corresponds to acute late phase in the ICU, which also corresponds to 80 to 100% of the measured energy requirements. And finally, to the recovery phase beyond 7 days, where the target is estimated to be around 25 kilocalories per kg or measured energy requirement. Among patients with refeeding syndrome or at risk of refeeding syndrome, more gradual escalation is appropriate and it should be pursued. And regardless of whether we give hypocaloric or full caloric feeds are provided at any of those phases, whether early or late, the protein requirement should be full, that is 1.2 grams per kg per day that should not be deviated or disturbed. So what should be the composition of the constituents? As I told, protein is often regarded as the most important macronutrient for promoting immune function and maintaining a lean body mass, and it is recommended to administer in the dose of 1.2 grams per kg per day, providing at least 600 kilocalories per day of carbohydrate, that is carbohydrate calories, that which comes from 150 grams of carbohydrate. We know that the calorific value is 4.1 grams per calories per gram, and because that is important to prevent starvation ketoacidosis. Excess carbohydrate administration may also promote hyperglycemia with increased insulin requirements, and if the tube feeding is stopped or interrupted in view of this increased hyperglycemia with continuation of insulin, then there is risk of hypoglycemia. Addition of supplemental fat calories should allow for the adjustment of the carbohydrates to be provided. That is, if this carbohydrates is failed to deliver the adequate amount of calories that this patient is supposed to give, the rest should come from the fat. And medium chain triglycerides oil is more easily absorbed than other forms of oil with less incidence of GI side effects, notably diarrhea. However, we should remember that in patients who are diabetic and poorly controlled, only 33% of the calories in the form of carbohydrate may be sufficient to avoid glucose variability. And also, there is greater likelihood of insulin resistance. The next question comes that whether parenteral or enteral nutrition. There is no doubt about the fact that early enteral nutrition, that is within 24 to 48 hours of intubation, and if it sounds too aggressive, 48 to 72 hours has also been found in the German society. So this has been consistently shown to improve outcomes like prevention of ileus, maintenance of gut integrity, avoidance of pneumonia, and stress ulcer prophylaxis. So initiation of nutrition within 48 hours is recommended by almost all the clinical guidelines that we follow. All intubated patients should be fed unless contraindicated for medical or surgical reasons. However, there are certain contraindications to enteral nutrition, like the gastrointestinal catastrophe in the form of obstruction, severe ileus, perforation, mesenteric ischemia, acute severe GI bleed, abdominal compartment syndrome, high output fistula, and so on. Even high doses of vasopressors is also contraindication to enteral nutrition because it might increase the risk of refractory shock. But if this will only applies to patients with whom the vasopressor dose of norepinephrine exceeds 0.3 to 0.5 mics per kg per minute, that actual blood translocation is the risk. At lower dosage, the patients can be given enteral feed. So following are not contraindications to enteral nutrition, like lack of bowel sounds, therapeutic paralysis if the patient is on relaxants, patient unable to lie in semi-recumbent position, prone positioning, pancreatitis, open abdomen, recent GI or abdominal aortic surgery, or low to moderate dose of vasopressors. So in all these cases, you can have to modify the amount of feed, but enteral route or enteral nutrition is not contraindicated. Enteral nutrition can cause mesenteric ischemia, but this is very rare and it occurs at extremes of risk, like in a patient on massive doses of vasopressors who are receiving full feeding. We know that in patients with septic shock, there is a component of NOMI or non-occlusive mesenteric ischemia. So, and which if to be avoided, we have to prevent. So these are rare conditions where actually enteral nutrition can cause some catastrophe, but otherwise it is very much safe and very much permissible in a wide variety of conditions. The next question that often is asked is whether gastric or post-pyloric feed. For most, there has been no significant difference in outcome between the gastric or post-pyloric feed, or in other words, to say that there is no increased risk of aspiration in a patient who is having a gastric tube is placed or a feeding tube is placed in the stomach instead of in the post-pyloric. Yeah? And both seem to be equal, but some medications may be better absorbed if administered within the stomach, like the amiodarone. And gastric tube placement is usually used initially since it is easier and it is faster to perform. And can be done and doesn't require any endoscope or followed by an X-ray confirmation of the position of the tip, etc. But post-pyloric tube placement may be useful in patients who encounter difficulty with gastric feeding and develop gastroparesis because they are at increased risk of vomiting, increased risk of aspiration, but no difference has been found in the risk of aspiration, in the risk of pneumonia, as has been reported from the studies. Next comes whether continuous or intermittent feeding. The main rationale for continuous feeding is that it is the most commonly employed technique, requires less work from nursing perspective because the infusion keeps moving, and it might be associated with a lower rate of diarrhea. But one has to remember that intermittent periods of fasting may improve insulin sensitivity, thereby reducing insulin requirements, improve muscle synthesis, which is triggered by pulsatile release of insulin and amino acids following meals, and improves the ability to reach daily nutritional targets. So probably if we consider scientifically as well as holistically, intermittent fast feeding scores over continuous fasting. And the most important factor which remains to be considered is that continuous feeding is non-physiological. It can lead to impaired resistance to stress, reduced autophagy, disarray of GI hormones, abdominal intestinal motility, and increased inflammation. And all these things are less likely to occur if the patient is put on intermittent feeds. Now, total parenteral nutrition is the other option if enteral nutrition is contraindicated or if enteral nutrition fails to meet the nutritional requirements. And in such cases, the patient is already malnourished. Enteral nutrition is not anticipated and either feasible, but we should always remember the risks or complications associated with TPN, like volume overload, metabolic complications like refeeding syndrome, hyperglycemia, hypoglycemia, hypertriglyceridemia, cholestasis, etc. And one should continue to monitor the glucose, acid-base abnormalities, refeeding syndrome, fluid balance, liver function tests, triglyceride levels, fever curve to make sure that there is no side effect which goes undetected at an early stage. There are certain practical tips and pitfalls that nobody knows exactly when or how much to feed, but there is an agreement that early enteral nutrition is good, that is within 48 hours of ICU admission. Gastric residual volume should not be checked routinely. There is often a tendency to measure the amount of aspirate and see, and if it is slightly more, say 50 to 100, to stop giving enteral feed. But no, this has no value or no role in nutritional stewardship. We have to monitor the electrolytes, particularly magnesium and phosphate, when initiating nutrition, because often these patients are malnourished for a prolonged period, and if the phosphate starts falling, we have to consider refeeding syndrome. If patient on enteral nutrition is developing refractory hyperglycemia, one should consider changing the enteral nutrition formulation before resorting to large doses of insulin, because the cause may be in the formulation. And always avoid interruption of the tube feeding for possible extubation or such procedures where by default the order may be written as stop feeding. No, there is no need to stop feeding to perform a chest tube drainage or a change in catheter or in extubating a patient routinely. So most studies with supplementation of micronutrients, which is another component, or it's another arm or an angle which has been explored widely in different situations, or using specific nutrient blends, but none of the studies have shown any benefit or harm except in specific subgroups where it has shown to more to cause harm. So the essential steps of nutritional stewardship program that needs to be followed in critically ill patients in the ICU consists of these arms, like implementation of nutritional guidelines, then guidelines adapted to the local context based upon already existing ones, and prescription approval with post-prescription review and feedback. And all of these are important to guide proper stewardship. The 6Ds framework of nutritional stewardship are as relevant as in any other form, like diagnosis, drug, dose, duration, de-escalation, and discharge from the ICU. Now, I'm not going to elaborate on each of important, but it It can be understood without any much difficulty that at any of the stage, if any of the Ds get mismanaged, then it will affect the subsequent D. What it means is that if the drug is not proper, then of course the dose is improper, and those doesn't matter. The duration also gets affected. The de-escalation strategy fails to give any benefit, and likewise. So if the duration is not adhered to, then de-escalation is also becomes meaningless, and the discharge also gets affected. So all this nutrition stewardship program should be measured in terms of performance, measuring parameters like with the minimum standards of prescribing, therapeutic streamlining, outcome measures, and in terms of cost effectiveness, which is very, very important. And they should be in concordance of prescription with institutional guidelines using an indication-driven approach. Now, most of these institutional guidelines that can be framed should encompass the other international guidelines, which gives a template, and these templates serve as a unique model to develop such a form of stewardship that can be amenable to the wide variety of patients. So the ongoing benefit of nutritional stewardship program must be demonstrated to the hospital management so as to get their support during the subsequent course. Now, these are the common guidelines which are followed. One is the German Society, DGEM. Another is the European Society of Parenteral and Enteral Nutrition. And another is the American Society of Parenteral. And now we, of course, have ISPEN, the Indian Society of Parenteral and Enteral Nutrition. And definitely Indian Society will also come up with its own guidelines in the coming days. Now, those guys, if you see the components of the micronutrients, the vitamin D, and the antioxidants and selenium, we see that the Aspen does not make any comment on the micronutrients and the vitamin D, whereas in Aspen and the German guidelines, there is certain amount of similarities, but there is also some amount of dissimilarities. In antioxidants or selenium, it is almost clearly stated that this should not be used as monotherapy and in high dose, because when they are of no proven benefit. So no recommendation regarding antioxidants or seleniums in critically ill patients is by and large the norm in all the guidelines. But given the controversial evidence, different recommendations can be found among the guidelines. And as we have more guidelines coming up in the subsequent time, we will also find even greater differences, at least on certain points. So my take-home message would be that critically ill patients require rapid, effective, and complete nutritional support management. And nutrition in the critically ill patient is not something that fits all. It is not a one-size-fits-all strategy. One has to individualize. One has to take into consideration the individual risk factors of the patients that matter most in those particular situations. A multimodal intervention for an optimal nutrition should be provided during critical illness, after ICU discharge, and following hospital discharges. It is not that the role of nutritional stewardship ends after the patient is discharged from the hospital, but it continues for a long time even after hospital discharge. Although that is not a nutritional stewardship of ICU, but that is another kind of nutritional stewardship which needs to be catered and monitored when the patient is at home. The cornerstone of nutritional stewardship program is implementation of the institutional guidelines, which should largely accord with international or national standards and should be augmented by audit and feedback, the quality use of medical indicators, and of course, the performance measures that I had shown before. Thank you. I hope this is helpful.